get to the agenda, I'd like to welcome Bill back from a brief leave of absence, and we're really happy to have you back on the board in person. And Reed will not be here today. So, so Ali, do I take roll first, or do I go straight to?
Yeah, you can go ahead and take roll, Robert.
Okay, so I'm going to take roll. I'll go from the bottom. Tom, are you here? Tom? Nope, not yet. Bob's here. Reed is not here. Dr. Sue's here. Susan Miller, are you here? No. Bonnie? Bonnie is no. Bill is here. Jeff?
Yes.
Is here. JJ is here, and I'm here. So I do believe we have a quorum.
Yes, we do.
Okay, great. All right. So
Robert, this is Susan Miller. I'm here now.
Oh, great.
Sorry.
Thank you, Susan. Appreciate it. And if you notice the agenda today, we have COVID-19 update, Eap Annual Report. The Joint Health Equity Group is going to give an update. And then after a break, we are going to look at health equity strategies and provider, and there's going to be a provider diversity report as well. So, and then our normal CIAO and innovation work group updates. So if I could get someone to approve the agenda. Oh, I don't have to do that here, do I? That's right. Okay, so if you don't mind looking at the minutes from last time, at the appropriate time, I'll entertain a motion to approve the minutes.
This is JJ. Move to approve minutes.
Okay. JJ has moved to approve the minutes. Do I have a second?
Bill will second.
Okay, I got Bill first. So Bill is seconded. All those in favor of approving the minutes signify by saying aye.
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 Any nays? All right, the minutes have been approved. Okay, so first up, let's just get straight to business. We have a COVID-19 update from both Kaiser and MODA. So it looks like Kaiser's going first. So Dr. Keith Bachman, are you ready to go?
Hello, good afternoon, and thanks for having us to do a little COVID update. Just do appreciate and grateful for all the works going in all of our school districts and all of our entities related to COVID. We feel your exhaustion just in terms of the changing protocols, the concerns about safety, on top of all the other work that we need to do. It is just to be kind to each other and be conscious of your employees. I mean, we are certainly facing significant levels of burnout and care fatigue among our providers as this lingers on. Certainly we are in an improving phase of the most recent surge, just as the state is, with some decrease in cases and hospitalizations and deaths, but still it's an intense level of COVID activity affecting everything that we do. Good news, or relatively good news related to vaccinations of OEBB subscribers and members with a 4% increase in vaccination rates, and subscriber vaccinations are getting very close to 90%, currently as of 89%, as I said, up 4% from last. That 90% is kind of a key number in our world. If we can get the community to 90%, currently with the increased infectiousness of Delta, that's what our experts and national experts feel it's going to take at this point for herd immunity. So anyway, OEBB subscribers at 89% most recently. Expect next time we come back, the number will be above 90%. OEBB members appropriate for vaccination, the rate's 82.7%. As with the rest of the state, we are starting to see the positivity rate reduce a little bit, and the hospitalization numbers reduce a little bit as well. For OEBB, in the most recent month in September, there was 2,950 tests that were done. That's both for symptomatic cases as well as exposures, as well as other reasons to be tested like travel or procedures. That number is down by 400 from the month prior. The positivity rate is down as well, down from 9.3% last month, down to 8.6%, but still much higher than it was back in the summer, where it was 2 to 4%. Number of hospitalizations have reduced to 8 in the last month, and only 1 case in the intensive care unit. These are consistent with what we're seeing across our book of business and in our hospitals, which still the impact of the 55 to 60 cases of COVID in our hospitals does have a significant impact and is impacting the availability of surgeries to a certain extent for things that may need a hospital bed after surgery. Since we last talked, we've expanded our monoclonal antibody program. Monoclonal antibodies are an intravenous infusion done when somebody is at high risk and is COVID positive and is symptomatic. The feeling is that infusion of these antibodies will reduce the rate of hospitalization and ICU stay. It's not super efficient. It probably takes 20 to 30 administrations to reduce one severe episode of COVID. So certainly vaccination is better. There's some limited capacity issues in terms of both getting the product and then ability to administer the product. We're sort of, because it's pretty inefficient to have people request it, we are looking at all the COVID positive cases that come in to our program and then stratifying them and then actually outreaching to the cases that we think are at the highest risk of requiring hospitalization or ICU level care. But it is available, mostly being done in interstate, and we'll make arrangements in Longview or in Salem when that's needed. Vaccination is ongoing. We're combining our flu vaccinations in with our COVID vaccinations. We're running 5 large vaccination centers. We've done 20,000 combined flu and COVID vaccines so far. We're also allowing or covering both COVID vaccinations and flu vaccinations at community pharmacies. Just a little medical content related to the third shot versus the booster. The third shot is for people who have immunosuppression or being treated for cancer or have cancer or on strong immunosuppressants who the science says do not get a great antibody response to the 2 doses of mRNA vaccine. So they will need a third vaccination done a month to 2 months after the first 2 series is complete. The other issue that's out there is what's considered the booster vaccination, and that's due to waning immunity. So we are seeing, particularly with the Pfizer vaccination series, decreased antibodies in around 6 months and increased cases. This is a little confusing because it's the same timing that the Delta came up as well. So the following groups of people we recommend a booster shot would be people who are greater than 65, people who live in long-term care settings, and people with significant underlying health conditions who are less than age 65. Other individuals may receive a booster vaccination, which would be people who work in institutional settings or have increased occupational risk, which would include educators with face-to-face settings or other essential employees. So any of those people will be candidate for 6 months after the Pfizer vaccine. Still pending decisions around J&J and the booster that's, I think, being talked about this week, and decisions around Moderna, which has not seen quite the reduction in antibody response. So currently people who've had Pfizer vaccines more than 6 months ago, who are employed in education or other high-risk settings, are eligible for a third COVID Pfizer vaccine, which we're happy to do, combine that with a flu shot that is safe to do at the same time in any of our our vaccination sites or at any community pharmacy.
Question.
Yes.
Dr. Bachman, what's Kaiser's position on mixing vaccine brands?
Right now, we don't recommend that. There hasn't been any CDC recommendations to do that. So everything is evolving, and we're waiting for further guidance. We know I would say it's a bit of a free for all, and people are doing lots of things. There isn't a lot of accountability in pharmacy settings, and actually, it's everybody's using self-attestation for need. So it's essentially anybody can do anything that they want, but there isn't recommendations for mixing vaccinations at this time. Is that concordant with what you've heard, Jeff?
Yeah, I mean, in today's world, when it comes to COVID news, there are contradictions out there.
Correct. And there's concerned people who want to move forward quickly and people who want to wait till the science is a little more certain. So it's hard to know.
Great, thank you.
We continue to looking at health disparities related to vaccination. We really want to eliminate those as best possible. And we are seeing improvements both in every geographic setting and all improvements related to race, ethnicity, and language with improvements in narrowing of the gaps, though that's not adequate. We have done special outreach in various community settings, partnering with community organizations, as well as Project Access Now. We've been working with Medical Teams International, who has a mobile vaccine clinic, and they've been able to outreach to more than 1,000 hard-to-reach individuals. We have offered grants to community organizations like the Oregon Latino Health Coalition and the Oregon Pacific Islander Coalition. We're having a new kind of fun thing that we're just starting this week in our clinics and other work settings, and having our teams come up and giving support, financial support is needed when teams coming up with innovative ideas related to vaccination in our communities. So more to follow on that. But again, we're out there. We want to do everything we can to support our members and the community and our valued employer groups in this work. We do think the vaccine mandates have been helpful, and we can definitely see some spike of vaccination activity related to that. I think I'll turn it over. Any questions about COVID?
Yeah, it looks like Susan had a question.
Good.
This is
Susan, you have a question? Yeah.
Yes, thank you. I was just wondering, when you said that they could be combined, the booster with the flu shot, are you saying with one shot, or would there still be
No, 2 shots, same day, different arms. There was initially, with the COVID vaccination, there was a recommendation not to do any other vaccine within 2 weeks of either before or after the COVID shot. Once the data was looked at more carefully, they found the antibody response was just the same. And so now it's permitted and fine to give it. We do like to separate the arms just so if there's a reaction, a large local reaction, someone knows which caused it.
Thank you.
Great. I think I'll turn it to Sapari, who had some information about flu shots.
Yeah, and Dr. Bragg, I know that you mentioned this briefly in your part of the presentation, but just wanted to add some additional highlights that our Kaiser Permanente members can get flu shots at no cost during an office visit. So if they have a doctor's appointment, they can get their flu shot done at the same time, or they can also go to one of our flu shot clinic locations, which is available throughout our service area. And then this year, we're doing something a little bit different for safety and convenience. We are actually having members schedule their flu shot appointments. And as Dr. Bachman mentioned, they can get both their flu shots and their COVID booster at the same time. And then lastly, to help expand the ease and convenience for our members, we also have contracted with participating retail, local, and national pharmacies, such as Albertsons, Costco, Fred Meyer's, Rite Aid, Safeway, to be available to provide flu shots to our Kaiser Permanente members. And all they need to do is provide their KP ID card for services, and they don't have to submit claims or anything like that. Jay,
So,
you have a
Sapari,
question?
can you, yeah, hold on. Can you go over the pharmacy or the locations that you're contracting out with?
Oh,
Is
absolutely.
Fred Meyer?
Yeah, so the full list includes Albertsons, Costco, CVS, Kroger, Rite Aid, Safeway, Save-On, Walgreens, Fred Meyer, and QFC. Yeah, thank you.
Thanks. JJ.
Have you seen any models that would show what we're expecting with a potential subsequent surge this winter? I know typically these viruses go crazy when people are inside and in bad weather. So have you seen any modeling that would suggest that?
The stuff I've seen most recently has been fairly positive, but there's huge uncertainty about it, recognizing that with winter gatherings as well as increased inside activity, things could get worse. I mean, I think the feeling from most of the stuff I've seen is that this surge is abating, and then we'll see what happens in a few months. But it's post-December.
Sapari, do you have anything else?
I don't, Robert. Thank you so much.
Okay. Keith, anything else?
Not for me, thank you.
Okay, let's go to Moda.
Hello, good afternoon. This is Dr. Popowitz. Hopefully I won't be duplicating too many of the points that Dr. Bachman made. But as of yesterday, overall, big picture, the CDC has reported 215 million people have received at least one dose of a COVID-19 vaccine, including 186 million people who have been fully vaccinated by the J&J single-dose vaccine or the two-dose series made by Pfizer and Moderna. In Oregon, 67% of the total population have received at least one shot, and 61% of the population is fully vaccinated. The state has used 78% of the doses allocated by the government, with 5,290,663 shots given of 6,766,000 doses delivered. The Delta variant remains the dominant strain, accounting for more than 99% of cases. So, as Dr. Bachman had mentioned, the CDC has endorsed a third dose of the Pfizer vaccine for Americans over 65 and adults at heightened risk of severe illness, for example, those over 65, long-term care facility residents, and individuals aged 18 to 64 who either have underlying medical conditions or are at an increased risk because of occupational or institutional settings, which includes first responders, education staff, workers in agriculture, manufacturing, grocery store, public transit, and the postal service, qualifying 6 months after the date of their second dose. Data on the Moderna and J&J boosters is still under review, and we are awaiting guidance on that. I'll now review our most recent data for our OEBB subscribers. This data is coming from vaccine counts derived from medical, pharmacy claims, and alert data as of 9/28. Overall, 77.9% of all OEBB subscribers have had their full vaccinations. This is up from 75.5% last month. For the regional breakdown of those members fully vaccinated, from highest to lowest, we see some incremental improvements in all regions. Portland Metro is at 87.4%, up from 86%. Eugene is at 82.8%, up from 80.1%. Salem is at 80.5%, up from 78.2%. The Oregon Coast is at 77.9%, up from 75.3%. Central Oregon is at 75.3%, up from 73.9%. Eastern Oregon is at 67.9%, up from 65.2%, and Southern Oregon is at 67.7%, up from 63.4%. Eastern and Southern Oregon continue to lag behind the rest of the state. There's optimism that the latest Delta surge may be waning. This is evident in the following case numbers. Overall, 3,895 members have had a COVID diagnosis. There were 361 in September, and this is down from 728 in August. Overall, 155 members have been hospitalized with a COVID diagnosis, 13 in September, which is down from 39 in August, and overall there have been 11 fatalities. Ongoing efforts of special interest, we've identified through our EOCCO network that several providers were not supporting vaccination efforts in Eastern Oregon. We've established provider workshops in that area to educate and inform, as well as to advocate, as Dr. Bachman had mentioned, for a combined COVID-19 flu vaccination initiative. The summary of our efforts to date, ensuring our members are informed of their COVID-19 benefits and know where they can access information about these benefits. Partnering with public health offices, again, especially in Eastern Oregon and Southern Oregon, where we've seen a higher level of vaccination hesitancy, and messaging to all members where we're continuing to encourage vaccination and providing its assistance to unvaccinated members who are open to vaccination, for example, finding sites, transportation as they need. I will turn this now over to Katie Sheeler, who's our Senior Clinical Manager of Pharmacy Services, to discuss updates on therapeutics that have emerged over the past month.
Thanks, Dr. Popowitz. Again, good to see everybody. I'm a pharmacist by training and happy to talk about the expansion of the COVID vaccines. On October 14th and 15th, so next week, we expect an advisory panel to the FDA to meet live on YouTube if you want to join and watch. I really enjoy kind of seeing the conversation around the evidence, but this meeting is to discuss the booster dose for Moderna and J&J vaccine. So as covered, we know that the Pfizer has been authorized by the FDA to have a booster dose, and we saw that J&J submitted data and an official request for a booster dose today. And so that'll be reviewed next week. And we're expecting Moderna also to submit an official request to extend the EUA to have a booster dose. That'll be discussed next week as well. They also are going to be discussing next week the idea of mixing and matching the different manufacturer COVID dose. So if someone had 2 doses of Moderna, can they get their booster dose as Pfizer? So that's going to be reviewed on the 15th. I do want to amend or say what was brought up, the question from Jeff earlier about mixing and matching. Currently, there is a recommendation for those immunocompromised who are getting their 3rd dose, that if they're unable to access the original manufacturer from the first dose series, they can get the other dose. For instance, if they had 2 doses of Pfizer and they're immunocompromised and they're supposed to get a 3rd dose, if they can't access the Pfizer vaccine, they can go ahead and get the Moderna, and vice versa. This is between Moderna and Pfizer only. Those are the only ones who are authorized for the 3rd dose for immunization. And then we'll see what the recommendation comes next week from the booster mixing and matching. It's also going to be reviewed on the 26th of October by the FDA Advisory Committee, authorization to allow children 5 to 11 years of age to have the COVID vaccine. So really exciting. We saw that data being presented to the FDA, and from that we hope will come a recommendation that it is safe and effective for our children to be dosed against COVID. One other update surrounds the monoclonal antibodies that Dr. Bachman briefly mentioned. Merck, we have seen in the news that Merck is manufacturing an oral monoclonal antibody called molnupiravir, and this is early studies showing that it may help people who are infected with COVID to not progress to be hospitalized or have death. So this would be better access than the current IV administration. So that's been in the news, and that will have to, the trial needs to finish. It needs to be vetted and then submitted to the FDA. But just to close, from a clinical perspective and also on a population health management perspective, of course, we're encouraging prevention of COVID through the vaccines and not relying on the authorized monoclonal antibodies to infected people to decrease hospitalization. And this is important not just for OEBB, who we wholeheartedly support, but everyone in Oregon, so we can protect our educators and our staff and ensure that when we're sending our children to school and our educators and outward facing staff has those interactions, that we're also protecting them from potential breakthrough cases or other types of risk. And that's all that I had, but Dr. Popovich and I are happy to take any questions.
Any questions, anybody for Moto? Okay, well, thank you so much for the update, both groups. Really appreciate it. Okay. All right, well, let's move on to the EAP annual reports. And I think we have Tanya, and I'm going to butcher this, but I'll try it, Barch.
That was perfect.
Okay, great.
Yes.
Okay, you can take it away.
Great.
Attachment to everyone.
Great. Thank you so much. Appreciate being here today and having the opportunity to share with you today. We do have a couple of announcements as we proceed, so we are going to talk about that. I'm going to introduce our new CEO, and then we'll get into that announcement, but then talking about the overall utilization over the last year and what we are looking for moving forward in the new benefit year. So with that, I am Tanya Barch. I've been with IBH for over 17 years and am the account manager now for the OEBB health plan and EAP plan. and really looking forward to expanding the utilization over this next year, expanding the new services that we've implemented effective October 1st, and just working with all of you. If you can go ahead and jump to the next slide, please, that would be great. I'm also very excited to introduce our new CEO, Mike Nolte, who is really leading our troops in moving forward in our new vision. And I'm going to turn it over to him for a few minutes to introduce himself and then also talk about what we are about to announce. So with that, Mike, I'd like to introduce you.
Thanks, Tanya. Appreciate it. First of all, thank you for having us. I appreciate the opportunity to speak with you for a few minutes. My name is Mike Nolte. I joined IBH about 4 months ago, and as part of our effort over that time, we spent a fair amount of engagement trying to think about how we position our business to be more digitally enabled and more customer service focused from responsiveness perspective. And as we thought about the opportunity to do that, one of the things that we saw come out of that was a chance to think about how we position from a branding perspective the company a bit differently. And so what I'm going to highlight for you is the new name of what used to be IBH, which is Uprise Health, and a bit of the sort of logic and thought process for how we got there, as well as where we're going from a business perspective. You know, there were really three things as I joined the business that were opportunities to change how we served our customers. One was investing in the responsiveness and the quality of our network. Second was an opportunity to invest in customer service and scale. And then lastly, using technology differently, and we'll spend a fair bit of time. Tanya will walk you through a couple things after I wrap up, to really think about how we engage members, not just in an incident or in a phone call or a teleconference, but really over the long run. If you could flip to the next slide. It really, started with a notion of how we brought really two ideas together. One is a great 30-year history with great customers like you, and an experience base in an industry where we had, a lot of opportunity to build relationships and build capability, and then combining that with technology as a way to change how mental health care and mental health services are delivered. We are focused on driving utilization by using technology in that services. We're focused on access as a part of this effort to rebrand. We want to use data and analytics differently, and are continuing to invest in that so that we can measure and manage what we do, and share reports and capabilities as we focus on new services and new products. And really, we want to be able to build worksite programs and responsive programs to help our members. And it all boils down to changing our approach to focus on not just mental health or EAP, but actually thinking about how we engage the total person over a period of time. If you flip to the next one. And so, as we think about repositioning the company as what's now Uprise Health, we have shaped really a different intent for how the business will be focused as we go forward. First is this sort of concept of focusing on the digital mental health company that cares for the total person, and recognizing that there's an explicit connection between mental and physical well-being, and that we have a history in chronic care management and caring for patients at a very different level, and that the asset that we can bring to bear to understand how those two things are linked is pretty powerful. Also, it's engaging technology differently for two reasons, really. One is to drive engagement over a longer period of time, and also to accelerate the ability for a member to get to the right care. So if they're calling for something simple, to be able to find that on their own, if they need services immediately, to be able to get quickly to somebody that they can engage with directly, and to use technology as a means to get services and even coaching and capability directly through software. And you look, lastly, this has always been true, but we have a passion for trying to do all of that with the same care and concern that we have for our own families and for our friends and communities. Look, the last one. And so as we engage on, the launch of this new brand, Uprise Health, the last piece for us was really thinking about how that is shaped by the culture that we're trying to build. And I won't go through everything on here because I know we only have a short period of time. But, we're focused on how we communicate with our customers and making sure that we do that frequently and transparently. We're focused on collaborating differently and engaging opportunities both internally and externally to work on new programs and new products. Simplification is a big part of how we've embarked on this journey. If you know our company, we came from a legacy of a total of about 7 different companies. And so figuring out how to drive scale and improve customer service through simplification is a big deal. And then lastly, it's that sort of cultural aspect and driving success by really focusing on how we drive engagement with our members and the folks that are on the phone with us in the same way that we would for our own families. Flip to the next one.
Great.
And that's just a quick snapshot of the logo. If you look for IBH, you'll find the new Uprise site. There's a lot of content and a lot more there, but we appreciate the opportunity to introduce the new brand.
Great, thank you, Mike. I'm going to switch gears a little bit here, and I just want to give an opportunity for any questions before I jump into reviewing the year-end utilization for OEBB. Okay. If you'll jump to the next slide. I think something that's really important to mention as I proceed through is that we worked really hard to make sure that the rebrand didn't impact our current members in the delivery of service. So the services that they're receiving today, they still access the same way. They'll still call the same phone number. They still have the same access code. And if they go to our website, it's auto redirecting to our new page. So really limiting that disruption to our members and getting them familiar with who Uprise is will be beneficial. The other thing is I will be talking about as we proceed, I will be sharing a little more about our digital platform and that solution, which is called Uprise. The app on the App Store is Uprise, so it should be somewhat familiar as members start going out and downloading the app. On the next slide, let's spend a few minutes just talking about what the utilization has looked like for the 2020-2021 benefit year. Last benefit year, we had 63,256 members on the EAP, or employee lives on the EAP, and the overall utilization as of Friday when I did the report was 10.6%. Now, Friday being the first of the month is a little bit early to run a full year-end report, so I do expect this number to increase slightly, but that is a pretty good guesstimate of what that year-end utilization is going to look like. Last year, we ended the year of the 2020 benefit year with 11% utilization. So we're right in there of where we left off last year. And I know with our new digital solutions, we're going to see that increase over this next year. We had a total of 6,730 services delivered in the EAP throughout that year. That's counting EAP services that were delivered, trainings that we did, work-life services, an overall picture of the total services delivered within the EAP. And your top presenting issues for the year are stress and anxiety as number 1, relationship and family concerns and issues, and life changes, And I'm sure that it comes to no surprise to any of us after the last year and a half that we've been through that, seems really right on target for what people are struggling with today. And it's my intention over the next several months to be looking at those specific topics and working with the communications team to develop and deliver resources that address those concerns and making sure that employees know where to turn when they're struggling with stress and anxiety or family relationship issues. On the next, well, before I move on, I'm going to move on and talk about the new year, but does anybody have any questions on that utilization as it is ending the year?
I do.
Tom has a question. Yeah.
Yeah. So do we have any information about the breakdown of people who are using the service in regards to rural versus urban, language preference, race, ethnicity?
We do not have that specific today. That is something that in working with the Willis Towers Watson survey, and just identifying some of those things within our reporting that might be missing, that is something that we've made aware to our reporting team. As of today, I do not have that information, but it is something that is being discussed and on our radar. We did launch a new reporting dashboard this year, and we have added additional reporting pieces where we're able to identify the age category, and we're reporting that back to you. So when I provide the full utilization report, I'll be able to share with you the age category that members are accessing, male versus female accessing the EAP. So it's going to also help us identify where are our highest utilizers and where do we maybe need to focus on additional promotion or more targeted promotion within those populations.
You should be able
Tanya,
to get.
Oh, sorry. Go ahead.
You
Tom,
should
sorry.
be able to get rural urban, I would assume, pretty easily.
I think we have, if we have the addresses in our system, definitely.
Yeah.
And I'm certain that we do. It's just not built into the reporting dashboard.
No, I understand that. I understand. Thank you. This is the focus now that OHA, the Oregon Health Authority, and OEBB as part of that is taking on is issues around health equity. And so particularly when as you talk more about technology, it's going to be, we're going to have to answer the question of accessibility to that technology also on the basis of language and just being able to afford the technology. So that those will be issues that you may not have answers for right now, but are ones that we're going to need to address over this next year.
Absolutely. Definitely hear you on that. It is something that is on our radar.
Perfect.
And, I'll definitely keep you and Willis Towers Watson involved in that communication.
Yeah, and just to be clear, I mean, the question you're asking is part of why we're sort of reshaping the way we go to market and the technology platform in the first place. It's, easy access to data about utilization, membership, and I think understanding, not just how to assess the population that you serve, but also how to better, increase utilization through changing our offering or changing our approach if it's necessary.
Definitely.
Tanya, I have a clarification question on utilization, the 10.6%.
Yes.
Does that mean that it's 10.6% of the total number of members? So in other words, 6,300 some odd people? Is that what the 10.6% is divided into?
The 10.6% is of the 63,000 members utilizing or that are eligible for the EAP. It's 10.6% total services.
Okay, so I'm just trying to compare that to total services. So we had 6,300 people use EAP, and then does that mean that maybe 400 have used it more than once?
It's possible that there are people who have used it more than once. So of those total services, oftentimes we'll look at that as, in general, this is the percentage of population that are being impacted or utilizing the EAP. Are there people who may have used it 2 or 3 times during the year? Absolutely. This report does not report specific unique users.
Okay, thank you very much.
You bet. Okay, let's jump to the next slide and just talk a little bit about some enhancements over the last year and what we're doing moving forward. So I just mentioned the utilization reporting dashboard, which we're really excited about. Moving forward, now all of the OEB entities have a 6-session EAP model, which I have heard really raving comments about that. People are very excited that they're able to offer that 6-session to their population. In addition to the EAP services, we've also added a couple of new peer support groups over the last year that we haven't announced since we saw you, but we've announced to employees, is frontline workers. We are now promoting online peer support groups for frontline workers and grieving support groups. And then we are also currently in discussion to add new support groups for veterans. And then I'm really excited to share with you that we're working on a new support group specific to educators. And so that's something that hopefully we'll be having come available within the next couple of months and be able to really promote that out to your population. I am going to spend a few minutes on the Uprise Digital Health. So I'll get to that in just a moment. But, and even before I get to the promotional campaigns, with the current EAP services and with the addition of the digital services, members now have many different access points to getting care. So those who are currently using the traditional EAP, of course, we want them to engage in the digital app and have those additional resources. But when they call in for services, they still have that traditional face-to-face option, but access to care is difficult right now. Providers are spread thin, and sometimes appointment times can be a little bit longer than the employee is willing to wait or needs to wait. And so we also have our virtual options, and those are really taking off. People are utilizing those every single day, but they have a choice between face-to-face, video, telephonic, and even chat and text-based options. So giving that choice to members, you may have people who are used to receiving the face-to-face and that's what they're comfortable with and want to continue that. And then you may have other populations who've never had counseling and they're not sure where to start, and going to a face-to-face option might seem a little overwhelming for them and might even prevent them from accessing care. And so with the digital solution and these virtual options, it's giving a lot more access to our members. And then with the promotional campaigns, just a few things that we're working on. One is I am going to be working with Jackie Coswell on some communication specifically to announcing the Uprise brand, rebrand. So we're meeting this week to go over that and announcing that to all members. I'm also working on putting together some live orientations, first of all, specific to HR managers and supervisors, to not only go over the digital solutions and EAP resources, but also make sure that they're aware of the employer services that they have available to them and are maximizing those to their benefit. I'm also working on providing live employee orientations to all of the OEB members, making sure they're aware of these new digital solutions. The biggest thing is getting them to download the app or getting them to log on to the website and engaging early on. And then our monthly newsletters are continuing. These are always, they come out obviously monthly, but they have focused communications in them. And then we're also promoting our live monthly webinars in those. So for example, the October newsletter is coming out, I believe by the end of the day, if not first thing tomorrow morning. In addition to Breast Cancer Awareness Month, which we're providing resources on that, we're also promoting Domestic Violence Awareness Month and making sure members are aware of the resources available to them in that realm. And then in the spirit of World Mental Health Day, which is on October 10th, our live webinar this month is titled Beyond Blue, Understanding Mental Illness. So that's just one example of those monthly newsletters that we'll be sending out and the webinars that go along with those each month. And then we also do specialty communications when needed. Oftentimes members will reach out to us directly or entities will reach out. For example, a lot of the wildfires this summer in Oregon, they were reaching out asking for additional resources, and we always are prepared and ready to provide those as well. Now I'd like to just spend a few minutes going back to that digital solution, and we can go ahead and jump to the next slide. And there's a lot of information that I want to share about this, but really I want to make sure that we're implementing this early on. People are utilizing this to the maximum ability, and that you understand what you've added to your EAP offering. And we truly are here to help that employer, that member throughout their whole health journey. And with you adding the digital solution, digital platform to your current EAP program, you have an extremely robust, digitally enabled EAP, engaging much more of the population than you are today. The digital tools are interactive, they're easy to use. There is a downloadable app right from the App Store, or the member can log in online if they choose to do the online web-based platform. The app uses AI learning to help us direct members to appropriate levels of care, as Mike said, getting them to that right care before they reach that crisis point, which is what we want to avoid. We want to keep our members happy, healthy, productive at their work, and living a good life. So there is a front-end assessment at the beginning of the app, and through that, we do risk stratification that helps us identify if the member's at low, medium, or high risk. And as Mike shared, we want to engage the member for a longer period of time. And so we're even engaging those low risk members. They're low risk, we want to keep them there. We want to be able to engage them in some self-guided cognitive behavioral therapy-based courses and tools where they can build skills to help them keep low risk. So when an event happens in their life, they're able to manage that in a healthy way and not turn to maybe unhealthy behaviors in managing or coping with the stress in their life. So keeping those low risk low. But it's also helping help the medium risk or middle of the road risk and kind of that yellow category, and getting them to that appropriate care as well. So not only do we want to engage them in those self-guided tools, but we also want to encourage them to access coaching, which you have available to you. They can engage with a coach either asynchronously through chat or as a live telephonic coaching session. That coach is there to help guide that member, whether it's guiding them through the self-guided programs, helping them practice skills that they're learning in those programs, helping them maybe engage in other resources that might be more appropriate. But and it may be EAP, other EAP services, but helping them just support that member through their journey. And then for those more high-risk members, we want to make sure they're being taken care of very quickly. So within 24 hours of them taking the assessment, we can do proactive outreach to those high-risk members to help engage them early on. Maybe sometimes they don't even know they're high risk. And something that I'm going to show you in just a moment, we don't tell the member they're low risk or high risk. We don't want to cause additional anxiety. We do let them know of areas that they can work on. But from the back end, we're able to tell that they're high risk, so we can intervene early on and help support them through their journey. And that may be determining they need to go to counseling. It may be determining they need to turn to their health plan for ongoing long-term care. But we're there to help guide them through that process. In the next slide, I'm just going to kind of bring all of this together for you. And this is what the digital platform looks like on the web-based platform. So the front-end assessment, as I mentioned, is an 11-question interactive assessment that the member will go through. After they've answered those questions, and as you can see, it's hard to see on the screen, but on the right-hand side of the screen, you'll see an overall well-being score and an overall stress score. So it's showing the member that your overall well-being score may be high or low. Higher is better, and we want to help you get there and raise that score. And the same goes for the stress score. We want a lower stress score, and we're going to engage you and help you lower that stress score. Through the answers that they've gone, or through the questions that they've gone through in the well-being check, their responses are going to help curate that content and personalized recommended courses for them to go through. There are core courses such as mindset, mindfulness, personal values, and things of that nature, but then there's also more defined courses. So a low risk member may be encouraged to go through mindset, may be encouraged to go through mindfulness, or even those advanced courses where someone who might be at medium or high risk might be encouraged to go through some stress management, or in my demo practicing or going through the other day with one of our clients, suicidal ideation was a daily course that came up. And so it's going to curate that content based on that member's responses. Each of these courses, as I mentioned, are cognitive behavioral therapy-based programs, so they're helping build skills. Each of them have a video at the beginning and then exercises, sometimes additional articles or FAQs that they can continue building skills. And we recommend that members go through each of these programs and spend about a week developing those skills. So after a week of practicing those skills each day, by the end of that week, they're mastering those skills and they're sticking. And that's the biggest thing, is making sure that they're sticking and carrying on with that member as they move on to that next program. As I mentioned, the coaching is also available by chat or by phone, and I'm going to show you in just a moment how members can access the coaching. And then lastly, our coaches can help get that member into counseling if that's what is needed. So if I'm a high risk member and I'm struggling, let's say with a relationship issue, and really, coaching and the cognitive behavioral therapy based programs are helping, but I need to have some of that long-term counseling, they will help me get to an Uprise clinician who will help me either access my telehealth or my face-to-face counseling sessions. On the next slide, as I mentioned, I just want to show you what that looks like to be able to schedule a coaching session. The member right from the app or from the web-based platform will be able to see the coaches that are available. So they'll see a photo of the coach, and there's a little bio of each coach, so they can go through and choose who they want to be their coach. And then from there, once they choose that coach, they can see the coach's schedule and know that in this case, this coach is available on all of these days that are bolded. And then once I pick the day that I choose, I would then choose the time and click book. And then I would have a scheduled coaching session with my coach. They will call me at the phone number I used to schedule or to register my app. So in summary, it's really us wanting to bring these resources together. And on the next slide, we really want to be able to provide one ecosystem for members to step through their care. So the ideal goal is, using that digital front door to engage and get started. And so that's my goal over these next few months, is promote as much as I can to get your members downloading the app and getting engaged and using these tools. Engaging with the virtual coaching for those that need that virtual coaching. The virtual consultations or face-to-face consultations, depending on what that member is looking for, they can choose to do their EAP counseling either virtually. And when they choose that, they can use their laptop, cell phone, tablet. As I mentioned, they can do that video counseling session right from their home, office, car, wherever they want to do that, which is also helping with access because people aren't spending time commuting to their appointments, and that's helping as well. But for those who still want that face-to-face option, we do have our national network, so it doesn't matter if they're in Oregon, traveling, if it's a dependent who's in another city or state, we have access for them to access that face-to-face, or we have providers to access that face-to-face care. So that I know that was really kind of more detailed or a lot of information very quickly. I'm sure you have questions, but really excited to see what this next year holds for us and for OEB and getting these digital solutions integrated within your population. Any questions on the next slide? I think it's just a questions slide.
Yeah, Jeff.
Yeah, I had to get off mute. What vision do you have, if any, and maybe this is directed at your CEO, for integrating or coordinating with primary care physicians?
Yeah, it's a good question. I think, our priority is to make sure that the mental health network, which is already under a lot of stress, is operating in a way that's more responsive, and to do our best using technology and services to be able to do that. I think as we continue to grow in serving sort of chronic care management and getting into other aspects of care, I think that's a priority down the road. But I think we have to kind of focus on, I think, what is today the more critical immediate need, which is, with a set of mental health providers that are overburdened, access for everybody is pretty tough. So that's sort of our number one job.
I was wondering if there are ways to perhaps leverage the primary care physician. I may be talking more behavioral health than EAP, but just curious.
Yeah, I mean, in what way? I would love to hear your thoughts. So.
Well, if you've got, for example, a child who's overly active, not paying attention, disruptive at school, whatever it is, and parents are trying to help manage that, the right place could be a combination of therapy and prescription ADHD drugs, for example.
Yeah.
And that would require a coordinated effort. Anyway, the thought.
Yeah, no, thanks for that.
Okay, I've got Tom and then Ali.
Is there, I assume that the website is in English. Is it, what happens to the person where Spanish is their major language?
I'm sorry, on the app today that we have available is English, and I believe, Mike, you might need to correct me on this, but I believe that they are working on a Spanish version now that will be available late next year, but I could be wrong on that, even on the date.
Yeah, there's investment in a Spanish language version. There's actually a couple other languages planned, but Spanish is the next one. But it's not available right now.
Okay, Ali.
Thanks, Robert. I just had a really quick question. When we looked at the PEB utilization, EAP utilization over the previous year, we were all kind of shocked it went down, fairly considerably. I saw the utilization rate earlier and just wondered if you could tell us if it was the same kind of situation with OEB.
As far as utilization decreasing?
Yeah. Mm-hmm.
I'm not seeing the decrease in utilization from last year. I know previous years we had seen kind of a decrease over a 2 or 3 year period, excuse me. But this year I was really happy to see that, knowing that there is some difficulty in accessing that face-to-face option because providers are spread thin, there's a lack of providers. But we've done a really good job. Our provider relations has done an incredible job of continuing to stay in touch with our provider network, surveying our providers, making sure that they're taking new patients. We have the correct contact information, all those things that, may have changed when COVID hit and some shut their doors, some moved to telehealth only. But I think also recognizing that we needed to have some of these virtual options available. So immediately within, I think, 2 months of going into social isolation last year, we launched our virtual option of the telehealth and video choices. It took a little bit of time for us to get people engaged in that, knowing it was available, but they're using it now, and their utilization report shows that they are starting to reach out to those other options. And I think, too, making sure that we have other resources. Sometimes people need help, but maybe they don't need counseling today. And so making sure that they have the choice between peer support groups and, some of those other resources that we've added to our EAP over the last couple of years to keep it, fresh, and making sure employees and members have resources available to them. You bet.
Okay, any other questions? Okay, I don't see any. Well, thank you very much. It's something for us to really go over into a deep dive later. So appreciate it.
Mr. Chair.
Thank you.
Okay. Scrolling back up. We are now at the update from the Joint Health Equity Work Group, and then we'll take a break after that.
And Robert, if this is Ali, if I could just say a few words to open this up. Thank you. So I just wanted to kick off the next few presentations and updates. Last year the board clearly established that developing policies addressing and achieving health equity was the top priority of the board, and ensuring that OEB members all have equal access to quality care and really the appropriate providers of their choice. And as Tom mentioned a few minutes ago, this really aligns with the goals of the Health Authority as well as the Oregon Health Policy Board, with the OHA's goal of eliminating all health inequities by 2030. And you all probably noticed that we have an agenda really focused on these areas today, with the hope of getting the board reoriented to this important work, which we hope to continue in future meetings. We all have different levels of training in the areas of social determinants of health and health disparities, and varied understanding of what health equity really means, and not just the definition, but what it means to you personally. So hopefully we can all elevate our competencies in these areas today and really come together at the end of the day ready to take some actionable steps. And really just wanted to set up Mr. Olson to give an update on our first Joint Health Equity Committee update. Thank you.
Thank you, Ali. Members of the board, I'm Brian Olson. I'm your contracts team lead, but I also do some committee and work group support work on the side, including supporting the newly established Health Equity Work Group for OEB and PEB. Just a quick reminder off the top that Tom and Susan are your OEB reps on the Health Equity Work Group. They're joined on the PEB side by board members Sean Parkman and Siobhan Martin. Before I provide some work group specific updates, I thought I would share just a little bit of summary information about what's going on with OHA, and this will be fairly brief just to paint a general picture. So OHA has created its own Health Equity Committee, which has developed definitions, values, and assumptions related to its work. Also, in its 2020 to 24 work plan, Healthier Together Oregon has incorporated various health equity concepts. OHA and various partners have been developing this plan, Healthier Together Oregon, for some time, and is implementing portions of it as part of OHA's COVID response. And just a note, as many, if not most of you know and realize, that employers all over the country,
we go to 4.
Employers are all over the country are looking at health equity, and it seems like employers are at all different stages as well. And for us, we're just getting this off the ground. So in terms of our health equity workgroup specific updates, so we have had our first health equity workgroup meeting. We have started developing tools, processes, and various agenda items to help guide the work this fall going into next year. We have developed and proposed a health equity screening tool to the work group. And this is a tool that asked a variety of questions in a variety of categories that deal not only with health equity, but other considerations as well, such as cost and ease of implementation, whether a policy is supported by evidence, et cetera. Where we are with the work group right now is we are working with both boards members to identify a couple of policy issues that we can run through this health equity screening tool. And then we will come back to the work group and we will see how this analysis and process works for them. And I think that's going to be a continuing theme for this fall, for the next couple of meetings. We will continue to focus on really the process, agenda items, and the tools we'll use to move this work forward. And then I really expect us to hit the ground running in 2022. So I think a lot of the work groups work will become more visible in 2022 than it is now. So with that said, are there any questions or any additional comments from you, Ali?
No, I would just offer to Tom and Sue if they had anything to share.
I think Brian's captured it well. Thank you, Ali.
Yeah, and this is Tom. As we're starting to include in all of our conversations, as we did with CIO today, we need to, when we hear of policies, when we hear of new interventions, we have to ask the question: is it taking care of all of our identified populations that we need to pay attention to? So it's we can't just look at the average anymore and say good job. We have to look at how things are happening for each component of the membership that we're taking care of.
Thank you, Tom.
Okay, thank you very much. We are only 6 minutes behind schedule, which is great. How about we take a 10-minute break and we'll be back at 2:16. Okay. Well, I'll see you in 10 minutes.
Hey, Robert.
Yes.
I just wanted to let you know I have kind of a hard stop at 4 o'clock. I know that the IWG reports last. So if Tom's agreeable, if we're running overtime, maybe he'll let me switch with him.
Well, when Tom's back on, we can ask him that. I don't have a problem with that flexibility.
I'm on, and it just took me time to unmute, and I am very willing to trade this for a player in the future.
You're such a prince, Tom.
Always trying to help.
I don't know what to think of Jeff thinking we're not going to finish on time, though. It makes me a little sad. Just being prepared.
I have confidence.
All right. Okay. So with that said, it's 2:16. Let's get back in the game. And Jenny and Brad are up with Health Equity Strategies and Benefits Attachment 3.
Good. Okay. So yeah, this is Jenny, and I actually have, I think Brad is on, but we also have another colleague, Drew Hodgson, on with us. Drew has been working with many of our employer clients on analytical tools to really dive into social determinants of health and really use that information to help drive strategies for our clients on this topic. So I wanted to have him kind of show you live how we can use this information. So he'll be kind of up a little bit later in the talk today. But I just wanted to start by saying, so Ollie asked us to, talk with you all about, because this health equity is a very important topic in general, and especially to the Oregon Health Authority. He was asking us, Jenny, what are other employers doing in this area? And what are some of the things that OEB maybe should be considering in the area of health equity? So we put together a few slides to have a conversation with you today about this. What I can say is many of our clients are very focused on health equity, but I would say it's a part of a larger strategy for addressing diversity, equity, and inclusion in the workplace. And because we work with a lot of employers, we have a lot of data just to help them frame the strategy and execute on it. So we're going to talk a little bit about that larger diversity, equity, and inclusion framework, because it really helps give you some context when we start talking about health equity. So Rose, do you want to go to just the agenda? Okay. So just as I mentioned, we're going to talk about diversity, equity, inclusion. What does that mean? What does that encompass? Why is it related to health equity, and why are employers thinking about this today, and why are they asking us to help them with their strategy? And then we'll talk a little bit about how health equity fits into that larger framework. And then I think the real interesting part is going to be towards the end when we really talk about, okay, given all of that context about what others are doing, how does that relate to what OEB is doing, and what are the areas that OEB can influence, because OEB is not necessarily a direct employer, but certainly since OEB is the main benefit provider, right, it really is important to understand how employers are thinking about their diversity, equity, and inclusion strategies, because each of the individual school districts and government employers are likely, you can tell me if this is correct, but are likely already developing their own DE&I initiatives. And so it's really important that the benefits that OEB offers support those efforts as well, even if they may be in different spots. Does that seem to resonate with you all at your individual workplaces? Okay, I'm seeing some nods, so that's good. Let's go ahead and move forward. Okay, so this is sort of hot off the presses. We did just recently field a survey of large employer sponsors or large employers and their benefits executives to ask them, of all the things that you're working on in terms of a benefit program for health and well-being, what are the things that are top on your mind? What are the top priorities in the next 2 or 3 years? So there's a wide gamut of responses that typically can come through. But what you can see here is that in our most recent survey, affordability, both at the employer and the employee level, continues to be at top. Employee well-being and creating that workplace culture of well-being has kind of risen to the spot number 2, I guess, if you combine those two. And then diversity, equity, and inclusion. Again, having that strategy for DE&I is, essentially in the 3rd spot in terms of what employers are thinking about doing and taking action on. What I can also say is that in all the work that we're doing with employers right now, this isn't really an HR initiative. These diversity, equity, and inclusion strategies are really coming from the top, the C-suite. There's a lot of data to support how organizations simply just perform better and have better attraction and retention results when they really have a formalized diversity, equity, and inclusion strategy. So it's really coming from the top, but a lot of HR executives and benefit folks are very involved in this work. So let's go to the next slide. Okay, so this slide really, there you go. This slide really just is we're framing what does diversity, equity, and inclusion mean for this particular conversation. So you can kind of read here, but essentially diversity is that blend of different colleague experiences and viewpoints and ethnicities. So it's helpful to have a diverse workforce and blend of employees to give you better insights. What goes along with diversity is inclusion. So it's not usually what we'll say is it's not good enough just to have a diverse workforce, but you really need to have an inclusive environment where all beliefs and viewpoints are heard and employees feel that they can bring their best self to the workplace to really contribute. And then equity has to do with being fair and impartial and providing the right opportunities to folks to help them do their best and be their best. And health equity, we're going to get into health equity and how that kind of plays into the equity piece of this tripod. But really, equity is sometimes gets confused with equality, and we'll talk a little bit about that later. It doesn't mean giving everyone the exact same thing. When we think about equity, it means giving the people the right tools to do the best. And when we talk about health equity, sometimes giving folks different levels of benefits or different levels of assistance within the benefit program helps them to have the same outcomes as others who don't really quite need extra assistance. So we'll talk a little bit more about that. And then around the edges, you can kind of see some of the different groups of folks, of employees that we tend to kind of use a specific lens for or start to dig into and understand the differences from each of these groups. Okay, so let's go to the next slide. Okay, I included this slide. This is another slide from one of our recent surveys of employer-sponsored health plans, or really HR executives. And the reason I included this is that, again, we are talking today ultimately about health equity and how that is a piece of the benefit program. But most of the employers that we're working with, diversity, equity, inclusion doesn't just live in the benefits program or even just the well-being program. DE&I initiatives are front and center in workplace culture and policy. So that's hiring, attraction, retention, employee resource and support groups, and just the way that the workforce is structured. And then just as important as employee pay, there's a lot of legal efforts right now to ensure equitable pay. And there's a lot of focus on that. And, you know, again, when we think about OEB doesn't really have a lot of interaction into the workplace culture necessarily or employee pay. We tend to get a little bit more involved with many of the benefit programs, but I would just say not all of them, because when we think about benefit programs in this bigger framework, we're also including retirement plans, voluntary benefits, time off programs, etc. And then OEB is also, you know, helping to support entity well-being programs, but certainly not the end-all be-all of each school district's well-being program. The other piece and the other reason that I included this slide is what you can see from the responses to those who are filling out the survey is that in each one of these areas, there's been a significant jump in the focus and thoughtful plans to do some assessment about where we are today and where we need to be in terms of diversity, equity, and inclusion in each one of those areas. So again, just kind of brought up a lot of this context because when we start to talk about health equity, there are a number of things that OEB can do and will recommend kind of taking a deeper dive. But it just is, I think, helpful for everyone on the board to understand that it's part of a bigger framework, and all of the efforts really should be thought about in terms of not only advancing the Oregon Health Authority initiatives, but also each individual entity's own DE&I initiatives. I'll take a quick pause. Any comments, questions so far?
I don't see any, Jenny.
Okay, so let's go ahead and move to the next slide. Okay, what do we mean by health equity? Just, we've got it here. A lot of this really lines up with what the Oregon Health Authority has also outlined in terms of health equity. It just means helping people live their healthiest lives by providing the support they need for optimal care and well-being. And it's not always the exact same support for each person. Sometimes different groups of folks need a different level of support. And it's important to understand what those levels of support are so that you can, you know, try to help. The other piece of the equation is eliminating disparities in how people access and receive that care. And those disparities are often based on the items that are listed here. And you've heard them mentioned in the board meeting today and then also in CL. So race, ethnicity, language, disability, gender, social, sexual orientation, and social class. So again, these are the things that health disparities can be based on. And we'll be digging in with you a little bit later in the talk about how do we look at this information. You know, what are some things that we can do with the information once we have it? And are there some pieces of information that we don't have today that would be helpful to have? All right. Let's go to the next slide. This is just a quick visual to explain how equality is a little different than equity, especially as we have this conversation about health equity. I think actually when I was looking through the Healthier Together that the Oregon Health Authority put out, they actually had a very similar picture. It just shows you that, you know, giving everyone the exact same thing doesn't always help everyone the same way. So I thought this was good. Let's go ahead and go to the next slide. And actually, Rose, let's go to slide 9 and I'll come back to this slide 8. Yeah, so social determinants of health are related to health equity. And so what do we mean by social determinants of health? Those are, you know, conditions in the workplace, economic, social conditions that impact health outcomes of our members. And it's not just necessarily how they access healthcare, but it's, you know, where they live, where they learn, work, and play. Many vendors and health providers or carriers are doing quite a bit in the area of social determinants of health in terms of doing a better job of analytics, understanding who these populations are, and doing some reporting to employers about how they're accessing care. There's a lot of work to be done in terms of those analytics. Even you were kind of hearing the EAP, Tanya mentioning that they don't quite have all of the reporting yet, but they're definitely working on it. And this is because employers are really pushing for this information, and plan sponsors. These 5 areas are kind of key areas of social determinants of health. So we've got healthcare, education, social support, income, and financial stability and environment. And once again, OEB and the OEB programs have some impact on some of these areas. But again, it's kind of a larger picture that we need to consider. So let's go back to slide 8, because I think that gives us a little more granularity in each of those spots. Okay. There's a lot going on with this picture, but it's the same 5 areas of those social determinants of health. And the things that are, the boxes that are filled in with a solid color are, when we talk with our employer clients, those are areas where an employer has some direct impact, right? So giving someone employment does impact their income and financial stability, for example. So the boxes that are not completely filled in and are just outlined, perhaps an employer has some indirect impact into that area. And then we went ahead and put yellow stars next to the things that are more benefit related. So I think the so what of this slide is really, it's important to understand all of these pieces, because you can't really just address 2 or 3 of the stars and without understanding the whole context. But it is good to know the things that OEB potentially can have an impact on, and those are the things with potentially with the yellow stars, as we think about health equity and that larger diversity, equity, and inclusion work. Okay, let's go ahead and go to the next slide. Well, we went through this one, so there you go. This is an example of using data and what data can tell us about how folks are using the healthcare system or potentially impacted by the healthcare system. So you've been hearing a lot of information in the news and different sources about how certain groups of individuals are impacted by the pandemic more than others. So if you can see here that Black and African American people are more than twice as likely to die than white people from COVID-19. And some of that is tied to the fact that when we see risks associated for the severity of COVID-19, asthma, diabetes, hypertension, and kidney, those tend to be more prevalent in Black populations. So, if we know that information, especially if we understand more about that within the OEB population, what kinds of things can we do with that information? What kinds of outreach can either OEB do, or that we can ask the carrier partners to do, or even ultimately the provider population to do? And we're going to get into a couple more examples that are more OEB specific in a few minutes. Okay, so let's go to the next slide. Here's where we start to talk about, okay, what I just talked about, I realize is a lot of information and can be a bit overwhelming, because these are huge topics and can take a lot of resources to really focus on. So what we've done for you here on this slide is to kind of hone in on, we're thinking about health equity and social determinants of health. What are some specific areas that OEB can start to look at? And now, we can do, or we work with employers to do some formal analytics in each one of these 6 areas. And how our clients use that information is a little bit, of a multi-year roadmap. So let's assess where we are today, and let's identify where we want to be, And then we make incremental steps along the way, either to the benefit program or asks of the carrier partners to help us move along the continuum. So I'm going to actually start with the middle one, which is affordability. So affordability, there are lots of analytics we can do with affordability. And I think what we'll highlight is, OEB has some information about how much healthcare costs members, how much their salary is, what that relationship is. OEB may not today have all the information to complete that picture, like, how much are employees or members actually paying for their benefits in terms of premium contributions? What are the employers providing in terms of HSA or HRA contributions? And how does that whole picture relate to whether or not folks can truly afford the benefits, or should OEB be establishing a point of view on the affordability of the various plans according to, some kind of a framework or a salary continuum. So certainly that's work that could be done. Plan design inclusivity. So this has to do with the policies and benefit eligibility rules that are present in the OEB rules or even the carrier rules. And there's some analytics or a diagnostic that we typically will do to help uncover what the language and the eligibility rules and policies, how they come out from a inclusivity standpoint. There's usually a good, better, and best outcome. So you can say, yep, we're kind of doing the minimum, or shoot, there's a few areas here where we might want to make some changes to our eligibility rules or our coverage levels in order to be more inclusive. And I guess an example of that is when OEB was considering a new, some additional coverage for fertility or infertility. Many of you may remember there was a discussion about, the carriers have different ways of implementing a fertility benefit. You can say, oh, the couple has to have tried several rounds of conception by natural means before the fertility coverage is allowed. Essentially what that kind of a policy does is it, impacts same-sex couples who really, aren't going to be able to achieve naturally or conceive naturally. And so they need to kind of move straight to some assisted fertility designs. So that's just one example, but there's several that we can look at. Moving down to the bottom, access and participation. There's definitely some things that we can look at in terms of how different populations are accessing the healthcare system and whether or not they have access to quality providers. And I think Drew's going to talk a little bit about that when we get into his demo. And then I would say going to the left, then member preferences. So usually in the work that we do with a lot of our clients, understanding member preferences is pretty key, or member insights, I guess I might say it. So doing some virtual or some focus groups with key constituent groups of members is super helpful, because you might see that a particular analytic says, oh, we have great access to behavioral health providers in, whatever county, XYZ county. And so that's not a problem. Folks should be able to get in just fine. But sometimes what you'll find from doing some member listening sessions is that, well, maybe they can't find a provider that's within that understands their ethnicity or their cultural preferences, or maybe they can't find a provider that's on a bus line, etc. Okay, and then we've talked a little bit today. We're starting to ask some questions of the vendors about the information that they can glean from from their systems in terms of these different groups. So there's things that you can do to be a little bit more formal about those assessments with the carrier partners. Okay. I think the last one that I didn't talk about was health risks and social determinants of health. And that's where I really wanted to introduce Drew Hodgson to talk a little bit about some of the analytics that he's developed for our organization and how we look at that information and what we can do with that information. So Drew, do you want to just introduce yourself real quick and then take it away?
Yeah, it sounds good. Hi everybody, my name is Drew Hodgson. I sit out on the East Coast. I lead our healthcare delivery national practice at Willis Towers Watson. And what that means is that I basically am a national resource for everything to do with the delivery side of healthcare. So that includes network solutions, centers of excellence, clinics, virtual care, those types of things. And as part of that, social determinants of health becomes a huge, huge chunk of what we do. I'm also an actuary by trade, but don't hold that against me. I don't do much of that anymore. I focus mostly on healthcare delivery. So what I wanted to do today is sort of what we did. Well, we have a modeling tool that we work with social determinants of health, right? We work with the Robert Wood Johnson Foundation. Robert Wood Johnson Foundation puts together health rankings or social determinant rankings across a number of about 30, 35 different categories across social determinants, from clinical care to access to social and environmental impacts, those types of things. So what we've done for this meeting, I thought would be valuable, is we've run the OEBB population through it. So we can take a look to see where the areas of concern could potentially be. So with that, what I'm going to do is I'm actually going to hopefully share my screen, and I will let me know to make sure that I have control and you guys can see that. Anyone see a map?
Yes, we can.
Perfect. Okay, excellent. All right, let me just orient you to what you're looking at. Most clients we work with, you see a lot of purple circles all over the map, but obviously with OEBB, we see a lot of purple circles in one place up in Oregon. What you're looking at is the population by county of where your population live. I'm going to go ahead and zoom in just to make it a little bit easier for you to see what we're looking at here. So we can see through here where your population resides, with obviously the biggest chunk being in the Portland area, but then a lot of largest populations out in the eastern side of Oregon as well. What we can look at here now, and what we've done, is take a look and see what the demographic profiles of those populations by county are. So this top chart here, what you're looking at, shows us total employee count we've got in the census file is around 65,000. The average age is about 47, the average salary about $49,000, and about 72% female. That's across the population. But obviously that's going to vary pretty dramatically county to county to county. So we start to try to identify, when you think about health equity and affordability, I know Jenny was talking a little bit about affordability and access to quality and those types of things. It's important to understand your populations by these different counties. You know, on that census file, we were also able to get race. So we can start to look and compare to national race statistics, which I'll show you in a few seconds. But to give you, just to orient you to what the charts down below show you, we're looking at how do people enroll? What plans are they in? That can help to address some of the affordability over here. Coverage levels, how many families have we got? How many singles have we got? Just the salary distribution, right? So we want to focus potentially on some of the low income folks making less than $40,000, less than $60,000 per year. Age, generational profiles, and then again, down here at race, you know, we're pretty heavily white. It's an 80% white population. There's a next category is a refused, and then we get into unknown, and then we get into more than one race. Black and African American population only around 1%, so 619 people in there. We don't have a lens from your census file onto the Hispanic population, but I'm guessing it's going to be relatively significant spread between some of these different racial profiles. What I wanted to point out, what I'm going to do here is kind of show you one county. Let's take a look at one county and see what we can glean from it. And I'm probably going to pronounce it wrong, is my guess, just because I'm not from the area, but Gallagher, is that correct? Hopefully I pronounced that correctly. You got 660 employees out here. If I click on it, we can immediately start to look to see what does that employee set look like? What does that population actually look like? we can see it's 75% female. The average salary dropped pretty significantly. So we're talking about a lower income group in this area with the same average age of 47. We can see it's a lot more families than we had before and a lot less singles. So we have lower income families in this area. If I come down here, it's a pretty similar distribution from a race perspective in that county. And keep that in mind when we move over to the other part of this, when we start to look at the actual social determinants of this county. So that's that county. If I then go over and start looking at the actual social determinants. So let me orient you to what you're looking at here now. Again, you're looking at counties, and again, you're looking at your population. But now we're looking at national data, not OEBB data. We're looking at what is affecting those counties based off of the Robert Wood Johnson Foundation data set across a number, and I'll go into a few of these in a second, across a number of different categories. That's what this is. In its simplest form, I'm going to zoom in now just so we can see it a little bit closer. In its simplest form, green is good, red is bad. What we've done is we've taken those county rankings and we've put them to a bell curve, and we've put the entire country in a percentile basis. So when you see red and a score for this county that we're looking at of 0.2, it means it's ranking in the bottom 20% in the nation for social overall composite score for health outcomes. Okay, whereas some of the counties here in Portland, for example, Washington County here scores in the top 10% in the nation, right? So this shows you the disparities in healthcare. On the right-hand side is not your race population, but the county's race population. So for example, the county we're looking at right now, the Malheur County, we're looking at 34.6% of that population is actually Hispanic that live there. Same principle in some of these other counties, we start to see it. We can start to look at any other race if you want to as well. If you want to look at the Black or African American populations in Oregon, it goes pretty light. There's not a significant Black or African American population in this market. The reason why this is important is we're trying to tie, and I'll show you a little bit more about quality later, we're trying to tie to say, okay, we know potentially, and we'll drill in a second, we know potentially the areas of concern, which counties in the nation are areas of concern where you have a significant volume of people. We know what the racial profile of that county is, and now we also know the racial profile of OEBB. We're also going to look at what does the quality of the healthcare look like in that market, right? What access do they have in that market? So therefore, how can we influence that market? So I'll walk through one so you get an idea of what I'm talking about. So again, if I go into that county again, I can now start to identify why is it orange? Why is it not green? Why is it scoring in basically 0.23, bottom 23% in the nation for health outcomes? If I come down here and look at the health factors, we can immediately see what's causing it. Healthy behaviors. Clinical care is still below the median, but it's a little bit higher. Social and economic factors are very poor, and the physical environment is poor. I can go a little bit deeper now and start to identify. So when I was going through this, ready for this meeting, and started to think about what would resonate with you guys to see how this works is, you know, what's driving these scores within that county. And we start with healthy behaviors. I can immediately see in this county that it ranks in the bottom 14% in the nation for smoking, bottom 3% in the nation for obesity. Its access to exercise is very poor. Teen births are poor. So from a healthy behavior perspective, it's an unhealthy population in that county. Social and economic, we start to see lack of college education, lack of high school completion, children in poverty, and unemployment rates being very, very high. Clinical care, which is something that we can really act upon from a healthcare delivery perspective. So I always sort of zoom straight into clinical care when I'm looking at things like this. Access to primary care physicians is in the bottom 3% of the nation. Having a lack of access to primary care is one of the biggest drivers of, in my opinion, of outcomes in healthcare. I think the relationship with a primary care physician is very, very important. And a lot of the new modern plans out there are driving towards that high value primary care. So when I see a county with a real lack of access to primary care, it's a cause for concern. The other thing that jumps out in this county, and I did notice when I was going through it with a bunch of the other counties in here, is screening rates and flu vaccinations are really low. This one's actually not that bad, but if I come up here and look at one of the other counties, I'm trying to remember which one it is now that I was looking at. Maybe it was Harney. Let's take a look at Harney County. We start to see mammography screenings and flu vaccinations scoring way at the bottom in these types of areas. So we can immediately identify and say, we're thinking about how do we solve for this that is causing that equity, that disparity in healthcare? Because if we were able to look at the claims data, that it's going to show the same story within these markets. And to sort of emphasize that a little bit more, I'm going to show you a different model that we have, which looks at healthcare quality. I'm not going to go into a huge amount of detail of exactly what you're looking at here. Basically, you're looking at every hospital in America. And if I zoom into Oregon, the color coding on here you see is actually quality metrics. We partner with a company called Quantros, who provides us quality metrics, outcomes quality metrics, not survey data, that type of stuff. It's actual outcomes, risk adjusted, across around 30 different clinical categories. And the reason why I want to point this out is you start to get outside into sort of the eastern side of Oregon. You've got this St. Charles Bend Hospital that scores very, very well in the top 2% in the nation overall. But you start to get in here into some of the, like the Harney District Hospital here. These are critical access hospitals out here. And a critical access hospital, for those who maybe not clear, are hospitals that are funded partly by the government in some situations because they are critical to the environment, to be there for access to care. If I come in here now, and we now know what's happening within that population in this portion of Oregon, and I look at, for example, cardiac care, I start to see a very interesting story around what's happening. I can see here that the Harney District Hospital, which is a critical access hospital, scores in the bottom 10% in the nation for cardiac care. Now, that's not surprising, and that's not a diss on Harney District Hospital. They don't have the resources. They're a critical access hospital. If somebody in this area has cardiac needs, where do we want them to go? We probably want them going to St. Charles Bend. We probably want them going into Sky Lakes Medical Center or some of these other areas where they can get the care they actually need. There's challenges to that, yes. There are centers of excellence type programs, which I know you've been working a little bit closely about. But you see the picture as we try to say, what's driving the social problems within the market? What's the access to the quality care in the market? Now we're armed with this information. We need to go to the health plans and say, what are you doing about this, right? What's happening in these markets? We can go to the health systems themselves and say, what can you do to support these environments? And what can we do as OEB, right? What is it out there? I haven't shown you a couple of other examples that are in here, but one of the big drivers in some of these counties, actually, I don't know if it was this one or not, where we were looking at food environment, where the access to healthy food was really, really poor. It's not uncommon when you get outside of major metropolitan areas where you start to see the only grocery store is a CVS pharmacy where you buy nothing but packaged foods. That's a food desert. We see that in some of these counties out there. And what can we do as OEB? What can we do to try to solve those types of problems? So that's kind of what I wanted to show you, what we're working through. And I would love to open it up to any questions or thoughts before I kind of turn it back to Jenny.
I think that you've stunned them with all of the cool analytics.
Whose data is that? Who has access to what you were just playing with there?
It's a Willis Towers Watson tool. It's one of 4. We have networks and quality and all the different pieces. The data is accessed by us. The Robert Wood Johnson Foundation data, which is the actual data that feeds this model, is actually from the Robert Wood Johnson Foundation and is actually publicly available data. We just took it, scrubbed it, created our own statistical modeling around it and put it into here. The data that is obviously OEB comes from the OEB census file. So we have the information on the OEB population that we're able to feed into the model. The quality model that showed all the different sort of hospitals, that's a number of different resources. We're pulling from the American Hospital Association, pulling all their information in. We're pulling in all the Centers of Excellence information because I didn't show you that part, but we can identify every COE in the country by every carrier through there as well. So we bring that in from the carriers. The quality metrics that I showed you, which are the reds and the greens, that is from Quantros, which is a now part of Healthcare Blue Book.
Okay, Sue and then Bob.
Thank you, and absolutely appreciate the analysis here. And yes, Jenny, not so much stunned as raises a number of questions. And I think this is something that we as a board need to be thoughtful about as we pick our way through these analytics. What truly belongs to OEB, what belongs to OHA, what belongs to the socio-political context of these communities. And I share this only, and Bob can certainly weigh in as well. One of the things that COVID has certainly laid bare in this state is how people approach healthcare and their personal beliefs relative to healthcare. So I think, I'm in Washington County. We're 90% vaccinated. We are far more, if you will, the blue progressives. There's a reason why people many times live where they do. It has to do with family. It has to do with tradition. It has to do with belief sets. And so I think it's going to be important for us as we navigate through this, that we understand all of the pieces, that we offer the services that are our responsibility. But there is a tremendous amount of opportunity for education. I just don't know what the opportunity is for success given the current environment. But it would be interesting, I think, as part of the analytics, that is also attended to in terms of helping us see the full picture of Malheur County and Harney versus a valley centric counties such as Multnomah and Washington and Lynn and Benton and so on and so forth.
Yep, totally agree.
Yeah, that's really well said.
Okay, Bob, and then Tom.
Drew and Jenny, I'd just like to tell you, I've said in a lot of these kind of discussions as it relates to healthcare and equity. This is the first time that I've said in one where I felt like information was coming to us that causes us to stop and think about what specifically could we do to make a difference. So I just want to congratulate you. I thought it was very thought-provoking, and I think it going forward, it gives us a lot of things to think about and ways that we might want to dive in a little bit deeper before we develop that action plan. But it was well done, very well done.
Thank you so much for that.
And then Tom.
Where I'm jumping to is, what do we do next with this information, and what's the forum for which we do this? Definitely the implication is there for us as the innovation work group works on centers of excellence. The other part, in a way, it's too much information when we look at all the different elements of the social determinants of health. It kind of boggles my mind. But it looks like we're going to need to do some collaboration with our carriers and our consultants, and try to figure out what is the best forum to dig deeper into this. It may be best done in the setting of the innovation work group, because my guess is PEB would be as interested in this information and approach. maybe, but we don't have the same consultants. So I'm not exactly sure. CAL may be a place where we can do a deeper dive into it. It almost feels like a half a day devoted just to really understanding this and seeing more of the of what the issues are.
Yeah,
and 30,
oh, sorry, go
30
ahead.
seconds more. If we didn't have a healthcare system in the state of Oregon, and someone came in and to design it, we would not have what we have now. And yet there are so many drivers here that result in the results that you just talked about. Like in small communities, hospitals being the largest employer in the community. And if the hospitals went away, the communities would be knocked off at their kneecaps. So, complex stuff, we're going to have to talk about it, think about it, and see in a way, what is our role in this whole thing? As we're, we represent 150,000 Oregonians, while there's 4.3 million here.
Yeah.
I'll shut up now.
I think it's valid commentary, and I think it's really well said. And you're not alone, right? I do these meetings across the country for a lot of very large employers. Some of them in urban areas that have significant problems, some have rural areas that have significant problems, and they're all very overwhelmed by the volume of information and the volume of data that is out there. But I think as you take small chunks and you start to look at it and look at the analytics, you really can make a difference. I really do believe that. I wouldn't be doing what I do if I don't think you could. The rural American challenge in particular is the most challenging one to try to address. But I think we're getting there. I think we're starting to come up with some solutions.
And I would just add, this is Ollie. We have been working on a board health policy lens that would run through policies like we talked about earlier. I think it may not be built out enough to include demographic data to this level, but I think data collection is definitely within the next year or two the top of the list as far as priorities to really move these things forward. Is having the information to address every issue within that lens, and we also have that vendor assessment tool as well. And I think these are good places to start. I think biting off too much at once might actually set us back rather than move us forward.
Yeah. Me first, and then Sue. I probably just restating what Tom said, but I think there's a huge jump between being aware of an issue and being able to even be more aware of it, and then coming up with solutions. And there's some capacity issues, at least for me. I don't know if I have the capacity to make those type of solutions. I think this starts down a very interesting road, but it's going to take some time. So, Sue.
Thank you.
So you're muted.
Of course I am. You think I'd have that down by now. Yeah. So I want to circle back, Ollie, to your point relative to policy, and because at the end of the day, that's what we are ultimately responsible for. And I think if COVID has taught us nothing in this state, it has certainly taught us that the minute you mandate, particularly to our rural partners, they will dig in a way that is counterintuitive. And so as much as we, as part of this, and Tom, I resonate to your comments relative to CAL and the innovation work group, to take these to go into those work groups to say, what is the bigs that we can get after, bring that back to the board, and then get into a conversation that instead of a cookie cutter response in terms of building policy, which is the easier way for us to go, how do we build policy that recognizes if you will, the differences, the cultural differences that exist when we talk about being, to your point, Jenny, around equity. What do you need for your context? How would we write policy that recognizes that and yet still gets to the larger goal? It's more challenging to do that, but it's work that my district currently is engaged in, is being thoughtful about the vision, but also about understanding that it's contextual, so that you have a higher degree of success with implementation than simply one size fits all and we hope and you're welcome, right? Because we'll not be able to address these analytics, the pieces that we own, unless we are willing to take from the grassroots up in terms of our own process, and then building a policy that takes that into account and makes it clear to our rural partners how this can benefit them, but still addresses the context in which they live and are the communities that they're a part of and are dearly connected to.
Yeah, I know there's a couple more people who have comments, which is good. I guess I was just going to suggest that having the lens with a lot of questions is really helpful to make sure that we're all, that everyone is thinking about a variety of different viewpoints and social groups or groups of individuals. But I guess I would challenge the group to think a little bit beyond that. And perhaps those 6 areas of analytics is just a lot, but I think you could make some headway by really understanding what analytics are available in each one of those different areas and how you would ultimately end up using it and what it would drive for OEB and ultimately for the Oregon Health Authority if that's the goal as well. And then you can try to prioritize, okay, which ones are the most important to tackle? And which ones are, maybe lower on the list, and then you map out, a plan of action over several years, because you're not going to get this all done right away. And it definitely needs partnership with the carriers and the provider community ultimately as well.
I tried to raise my hand. Seems to me there needs to be some discussion as to where this belongs, whether it's IWG or CAO. Perhaps leadership can have a discussion before the next meeting as to the pros and cons of where it might sit.
Yeah, that sounds very good. So Drew, this has sparked a lot of good conversation. We're at 3:07. How much more time do you need?
I'm about wrapped up with what I was going to look at. This one last chart here is just showing you the entire population so you can see which areas are of concern across all of the state. But other than that, Jenny, I don't know if you wanted to go to the other slides, how much time you need for this?
I actually think that's a good way to wrap up. The other slides, and you can all kind of take a look at them, are just samples of the types of analytics that we've done, again, with other clients who are, like, maybe if you want to go ahead, Rose, a couple of slides, maybe 3 or 4 more slides ahead. This one here, let's stop at the one prior, the mental health. Yeah. So again, this is just one sample of where you can use some of these analytics to really understand, the impact of social determinants of health on mental health. And again, this is all going to be a result of once you go through and decide what are the areas that we want to focus on over the next few years, then we can kind of drill down into, at the end of the day, which pieces and parts are going to be the most useful to OEB in your work. This is just an example, and the next 3 slides are also just examples. So I think that's just a really nice way to wrap up the discussion. Okay.
Yes, I was just looking. Yes, I think this is very informative, and the The leadership group will find the right places for further analysis and discussion on this topic. Okay, thank you so much. And we are ready to have a couple of diversity reports from our providers. And it looks like Kaiser is up first.
Great. Well, thank you very much. And this will be a great, the material that we're presenting today is actually a great follow-up to what we just heard and are thinking about. I have two of our experts in this area with us today. First, we'll have Dr. Ruth Chang. She is a family medicine physician, and she's the vice president for people operations and the chief people officer of Northwest Permanente. And really much of the work that she does, whether it's in developing leaders, recruitment and retention, our organizational diversity strategy really relate to these issues in part, and she's been a champion for these issues really over her whole career. Our second speaker today will be Nicole Freeman, who is Senior Director of our Social Health Community Engagement Program. And that's really the team of navigators and others who look at these social determinants of the health that our members face, and they come up with an action plan how to deal with them in a very complex way. The conversation today is really just a highlight or a snapshot or a thumbnail of all the work going on within our organization on these topics. This work is important. It's deeply intertwined with our mission and deeply intertwined with the health of our members in the community. So with that, I will turn it over to Dr. Chang. I think we can go ahead, and the next slide is pictures and their bios, and the next slide will be the agenda there.
Okay, great. Thanks so much, Keith, for that introduction. So again, I'm Ruth Chang, and pleasure to be here today. So I'll be presenting the section around provider diversity, and I'll turn it over to my colleague, Nicole Freeman, to speak about how we're approaching social determinants of health. But when I'm thinking about provider diversity, really ultimately our goal is to promote equitable health outcomes. And we believe that provider diversity is a really key strategy in achieving that goal. So we know from literature in that when there's racial concordance between patient and provider, and also language concordance between patient and provider, that the patient will have better outcomes, better adherence to treatment plans, better understanding, and ultimately a better care experience. So that's what we're after at the end of the day. So through this work of provider diversity, we will expect to see a reduction in disparities, so removing the barriers to care, creating a more inclusive care environment, and then have more effective communication, whether that is through language concordance between provider and patient, or leveraging technology and other systems to ensure effective communication. So we'll go to the next slide. So speaking a bit about our current state and our recruitment strategies. Again, oh, I'm sorry, I have a echo here. One of our key issues is that we know we want to intentionally recruit for diversity. And we've had instituted a 3-year plan in our medical group on how we will achieve that. So first is we have to measure what we want to change. And we've created an equity, inclusion, diversity dashboard for our talent acquisition team, and really looking closely across departments, who's our demographic makeup by ethnicity, by gender, and then who in the future would we be specifically recruiting for. And what we see is that ultimately our goal is we want to be as diverse, if not more diverse, than the population we serve. And we know that we have underrepresentation in Latinx and African American physicians and providers. So we are now intentionally building those relationships and recruiting at such as the National Medical Association, which is the African American Medical Association, or the National Hispanic Medical Association conferences. We're intentionally reaching out to medical schools from historically Black colleges and universities, as well as medical schools that have a higher Latinx and Indigenous population of students. So that's part of the recruiting strategy. And then a lot of it is also, what are we doing locally? One of the issues that we saw is our current medical school graduates in the state of Oregon is not as diverse as the population of Oregon. So we know we have a pipeline issue. And part of addressing that is really investing in the communities we serve. At Northwest Permanente and Kaiser Permanente, we have built programs starting with our middle school kids to encourage underrepresented minorities to consider a career in healthcare. So we're really teaching our 7th and 8th graders that being a doctor is possible and is a great profession. So we're investing in those pipeline programs. Next, we have high school scholarships to encourage students entering to healthcare profession. And we have paid summer internships for college and post-college students as well. And I just want to emphasize that it's important to have paid summer internships because the students who can afford to work for free during the summer are not necessarily the underrepresented minorities that we ultimately want to see in healthcare. So we're investing, putting dollars behind our words. And then another way that we're putting dollars behind our words is Kaiser Permanente opened the Bernard J. Tyson School of Medicine and made the first 5 incoming classes tuition free. And again, that was a specific strategy to recruit for diversity. And in our inaugural class, I'm really proud to inform that 56% of the inaugural class are Asian, Pacific Islander, Black, or Latinx, and 36% come from social economically disadvantaged backgrounds, 30% from the LGBTQ+ community. So we have, I would say, we've successfully recruited for diversity in our medical school classes. Then in our current environment, we also spend quite a bit of resources and time in ensuring that people get the training and education they need to deliver culturally competent care. We have a national program this year called Belong at KP, which is training on unconscious bias, creating a respectful environment, and how we can listen to every voice. And this is a nationwide effort across all 8 KP markets, and we serve over 12 million members. So this is something that we are really looking forward to see how we can make a positive impact through this systematic training and education of all of our staff. So on the next slide, what we're sharing here are the numbers. So this is looking at the diversity of our physicians. And as you can see, 63% of our medical group are white, and then 24% Asian, and 2.7% Latinx, 1.3% African American. So as I mentioned, we know that we have that opportunity to be hiring more Latinx and African American physicians and clinicians. So looking at how this, the medical group diversity compares to OEBB, the numbers that I have that our marketing team received is that you're 77% white, 3.6% Asian, 14% Latinx, and 2.3% African American. So again, we know that there's a gap and that we will continue to pursue and recruit more Latinx and African American doctors. One of the questions that does come up is, so we have this great diversity in providers, and we're continuing to add more diversity, but are the physicians accepting new patients? So the short answer is yes, in that we go through open enrollment every year, and even for physicians who have long tenure with us, we know that there's turnover in the patient panel every year. So our goal is to have as many panels open as possible during open enrollment so that our patients have as much choice as possible. And in the next slide, we are really wanting to make it accessible for patients to choose a provider. As I said earlier, language and racial concordance is often very important for patients who come from diverse backgrounds. So on our kp.org website, we offer the bios, the photographs, list the languages spoken and gender of all of our clinicians. And in our search website, we have the gender and language function search as well. So again, that's all ultimately to better serve our patients. In the mental health arena, we also know how important this is and have built into our triage process a way to ask patients about their preferences for language and culture and background of their provider. And in our mental health team, they have done extensive training beyond the Belong at KP, but really extensive focus training on culturally competent care. And ultimately it is to best serve our patients. We are also leveraging our technical platforms. And I think one potential silver lining of COVID is really the widespread adoption of telehealth and telemedicine. And now when we have our providers who are Black or Latinx, it is easier to match them up with the patients who are asking for a doctor that looks like them, because we can leverage telehealth. So if we have our doctors in Salem with the patients in Portland, we can still offer that telemedicine as a way to connect the patient and the provider. On the next slide, just wanted to dive a little bit deeper about our process of matching patients and providers in the mental health arena. I know that one of the issues that comes up in open enrollment is patients, when they already have an established relationship with a mental health provider and they feel like it's working well, we often get that question of like, can I keep my mental health provider? So what we do is we go through this systematic review. Is one, first just checking the licensure and the credentials of the provider that the new member is seeing. And then we will also look within our Kaiser Permanente network to see if we can meet the needs. So if we have a mental health provider that speaks the same language, same ethnic or racial background, same experience, then we'll offer that to the new member, but also issue a series of transition sessions so that they can wrap up with their current mental health provider and then transition to KP. If we find that we're not able to match what the member needs, though, we will issue a spot contract and then bring that provider into the KP network. So ultimately, again, we are here to best serve our patients. And all of those efforts that I described, with updating bios, making sure that we have specific prompts for when we are triaging patients, again, it's to best match up patients and their providers. On the next slide, this is also just touching base around what we are doing to collect the information of REAL-D, which is for racial, ethnic, languages, and disability status of our patients. So this has been a DHS requirement, and we are fully implemented this survey system. So as of September 2021, we have gone live completely. We've already sent out over 50,000 surveys, and so far have a 15% return rate from our patients filling out this fairly comprehensive survey asking about the REAL-D data. Ultimately, these data is going to help us better serve our patients and offer better language concordance. So that is our overall overview of provider diversity. And with that, I'm going to turn it over to my colleague, Nicole Freeman, to talk about our approach to social determinants of health. So Nicole?
Yeah, thank you so much, Dr. King. We can go on to the next slide here. So yes, I'm here to talk about Kaiser Permanente's social health strategy. And the key takeaway here is we think about social health not as a separate initiative, separate program, or separate thing. It is fully integrated and part of how we think about a person's holistic health, their physical health, their mental health, and their social health. And when we dive into social health, there's two core entities to it. There is social health for our communities. A lot of the work that we do in capacity building, grant making, for example, the many millions of dollars Kaiser Permanente and other health systems contributed towards ending houselessness in the Portland metro area in the past few years. And then we think about what does our social health practice look like for our members? So how do we address the unmet social needs at the individual level within our own membership for patients who are struggling to afford their insulin to manage their diabetes? So therefore their diabetes is getting worse and worse, and we're not providing or prescribing the right intervention, which may be financial support or access to healthier food and nutrition. When we think about the social health practice for our members and communities, they're closely connected, because the more data and information we know about our own members, the more astute we can be in how we build capacity and partner with community-based organizations that address these issues. And we're laser focused on 4 areas of unmet social needs or social health, because we know that there's a growing body of evidence that these 4 areas have the largest impact, both on health outcomes, on quality, and also affordability. And those 4 areas are food security, housing, financial well-being, and transportation. We can go to the next slide, please. Okay. So diving in a little bit to our social health practice, so the work that we're doing across our membership. And this is happening both in the Northwest, but also we're taking this work national to scale as well. So there's 3 components of our social health practice: identifying unmet needs. Once we identify patients with unmet needs, how effectively are we connecting them to needed resources or interventions to address those needs? And how are we deploying tiered interventions, knowing that some patients may be okay just getting the resource information for a food service or a transportation resource, but a subset of patients are going to need more kind of care management support and follow-up to address more long-standing complex social needs that are interfering with their medical complexity. So starting over on the left, Kaiser Permanente has committed to universal social health screening for our patient population. In the Northwest, we are screening for those 4 core domains: food insecurity, housing insecurity, financial strain, and lack of transportation. By 2024, our goal is to screen 70% of our total membership nationwide, so 70% of over 12 million patients. And we're happy to report that in the Northwest, we've already screened 17% of our total membership. This screening is happening in primary care, it's happening in specialty care, it's part of an initial assessment a patient gets when they're admitted to the hospital, and we're about to launch a digital self-service screener so that patients, regardless of interaction with the healthcare system, can take a social needs screening and get connected to resources. And this screening for us is really important for two reasons. One, it allows us to think differently about how we do population health segmentation. So instead of being able to identify our patients who are struggling with diabetes or heart failure, we're now going to be able to segment our population and understand who are our patients with heart failure and diabetes and who endorse food insecurity or who don't have transportation to their needed cardiac appointment. And that changes the intervention. And we believe firmly that while we're still using other inputs such as census block data, some of the great information that was presented before, we really need to understand the unmet social needs at the individual level to make that impact. So then we can understand it at the population and community level. So the more we can be targeted in our screening, the more effective we believe we can be to get to that improved community outcomes. I want to talk a little bit about what are we doing after we screen. We're not screening just for screening's sake, but we're building a robust social health infrastructure in partnership with community organizations, social service agencies, and many others to address these unmet needs. A few examples I want to pull out of here. We have Kaiser Permanente was a catalyst with other health systems for our Thrive Local or Connect Oregon platform. This is a scaled platform actually across our entire enterprise that allow, in the Northwest alone, we have over 3,000 community organizations in a resource directory, fully embedded in our electronic medical records so that providers can actually make referrals directly through our Epic system to services such as Meals on Wheels people or various other community-based organizations. And we get a closed loop. We are actually collecting data on not just did we give this information, but for a subset of these organizations that are on the network, we can know if the patient was served and the outcome of that resource connection. We're also doing a lot of work in the housing space. Coming November, we're going to be embedding a public defender in one of our large clinics to support health harming housing issues, particularly focused on our Black population in North and Northeast Portland. We understand that, you know, with the eviction moratorium, rising rents, and other issues, it disproportionately is affecting communities of color. And we really want to expand that traditional medical care team to include other kinds of social sector services. And we believe lawyers can make it impactful, be very impactful on the care team. This is an evidence-based model, really well established on the East Coast, and we hope to be a catalyst for this on the West Coast as well. We have a partnership with Medically Tailored Meals. We're using Meals on Wheels people to deliver 30 days of medically tailored meals for patients discharging from our hospitals, the Westside and Sunnyside Hospital, to ensure that patients with heart failure, diabetes, and other chronic conditions have adequate nutrition that's tailored towards their specific chronic condition and why they were admitted. We're evaluating this. It's a research program, and we're looking at not only did patients endorse that this helped their follow-up care plan, but that they didn't readmit to the hospital because of lack of adequate nutrition. So we're really excited about that. We have about 500 people participating. And then lastly, Dr. Chang spoke eloquently about our health equity strategy. Across all of the social health and our social health practice, we understand that we need to fully integrate this with our health equity agenda. So as we think about our strategic partnerships and the unmet social needs that disproportionately affect Black, Indigenous, and other people of color, we're being really strategic in our community partnerships. And what I want to call out is our partnership with the Healthy Birth Initiative, which serves Black pregnant women in Multnomah County. We know we have health opportunities to reduce health disparities nationally for Black pregnant women, and this partnership is going to help us better serve this population. So we're being very strategic, not only in the unmet need, but who and how we're partnering and bringing equity, diversity, and inclusion to part of this work. And then lastly, before I kind of summarize and finish here, is I'm really excited to report in some of our tiered intervention, we have deployed a robust community health worker model in 2 of our large clinics in East Portland and are looking to spread that. These are community health workers who have a caseload of patients with complex medical and social needs. They follow them for 30 days to 3 months, really addressing their person-centered goals, helping them remove the social barriers to care, getting them connected to internal Kaiser medical resources. And we did this as a control trial, so a randomized control trial, which was very rigorous. And we've seen a 50% reduction in hospital days per member per month in the past year for patients who've graduated this program, yielding a significant return on investment. So we'll be looking to spread this because it's the right thing to do. It contributes to affordability. And we've seen that it's particularly impactful for our Black and Latinx population who enroll in this program. So an equity agenda as well. Next slide, please. So just to summarize, I talked a little bit about our social health practice, the screening goals, some of the strategic interventions, and how we're really tiering our follow-up with new roles like community health workers who follow patients more long-term to address their unmet need. This is some of what's coming down the pipe. So, our screening goals by 2025, we're well on our way. We have our Thrive Local resource directory well set up and established and scaled. Nationwide, we have more than 26,000 resources in our directory. And 40 active community networks will be available to all members across our footprint by the end of the year of 2022, excuse me. I talked about some of our food initiatives with medically tailored meals, and forthcoming as we grow our social needs screening, as we get more information on our members' social needs alongside their medical needs. We're looking at building a large platform to track their social health data and how effective are we in closing these social care gaps, and is it contributing to better health outcomes? Is it contributing to reducing health disparities, and are we making care more affordable? So we're taking the big picture view on this and making sure that it yields back to our overall mission. So with that, we are done and available, I believe, for questions or clarification.
Well, personally, I thought that was very clear and very informative. Any questions or comments? Okay, Seeing none, let's move over to MOTA. Thank you very much.
All right, Karis, do you want to get us started off?
Absolutely.
Thank you.
Good afternoon, everyone. I'm Karis Stoudemire-Phillips, MOTA Vice President of DEI, Diversity, Equity, and Inclusion, and Community Initiatives. MOTA's commitment to diversity, equity, and inclusion runs deep. Simply stated, it is part of our DNA, who we are, and who we always will be. MOTA is not only a health insurer, we see ourselves and desire to be viewed as a health partner. OEBB employees who you all represent are more than just MOTA members to us, and we want to partner with each on a journey to overall better health. A part of the journey to better health includes the recognition that everyone's health journey is different, and that race, ethnicity, heredity, social impacts, and more affect health outcomes. In 2016, we established MOTA's Diversity Council. As a founding member of MOTA's Diversity Council, myself and colleagues committed to actively dedicating our time to formalize how we at MOTA celebrate diversity and create an inclusive workplace. The council, both then and now, is composed of MOTA employees from every level, top down and bottom up, meeting in the middle, with each possessing an equal seat at the table as a contributor to our collective advancement and success. The committee is focused on health equity, language access, marketing, vendor DEI, recruitment and retention, training, and business development. We further expanded and deepened our commitment to our focus on diversity, equity, and inclusion in 2019 with the creation of our board DEI committee. The committee charge is to assist the board in fulfilling its oversight responsibilities with respect to the company's goal to support our current and future employees by providing an environment which promotes diversity and fairness and which offers an equal opportunity for all. I'm extremely proud to tell you that we recently, both internally and externally, shared our vision and dedication to diversity, equity, and inclusion, and it reads, "Here at MOTA, we're committed to making healthcare work for everyone. We realize that truly standing by this commitment means understanding that this goal isn't one of equality, it's one of equity. It means truly seeing our members, hearing their unique needs, and acknowledging that those unique needs are often directly tied to systemic disparities that exist in not only the communities we serve, but also throughout our entire country. And paramount to being empowered with this knowledge, it means doing everything we can to understand how to participate in building a more just society. Social injustices have served as a reminder of how crucial it is for these elements to be a measure in doing right by our employees and communities. Crises that disproportionately affect communities of color and other marginalized groups continue to leave us feeling helpless at times. But at our core, we believe that with a new day comes the opportunity to be better, to work harder and faster to create measurable change. Through this lens, continuing to establish equity within our own walls is crucial. By not just building a more diverse workforce, but also by supporting that workforce through inclusion, education, and opportunity. And by creating spaces that allow for crucial conversations and transparency at all levels. We fully embrace these efforts that will better equip us to support our communities. We know these goals will not be achieved overnight, but they are achievable and we are committed. We will be better, we will do better. It is the right thing to do, and we expect it of ourselves. We are proud of our declaration. It is strong and impactful, and it's relevant to MOTA, reflecting our business, our commitment, and firm stance on our direction. It is not enough to simply state that we believe in and support equality. Equality means the state of being equal, especially in status, rights, and opportunities. That is just not enough. We must strive to attain equity, the quality of being fair and impartial. As we state, our members have unique needs, and we will be both fair and impartial in serving those needs through a lens of understanding. Now, please give your attention to my colleague, Dan Toma, who will share about our behavioral health provider diversity. Dan.
Thank you, Karis. If we can move forward about 3 slides, I think. And there we go. So I'm going to start out and give a little bit of background information related to provider diversity in our behavioral health panel, and then also speak to how we support our members both in behavioral health and the medical side of things in terms of being able to access providers who match their own background. So in behavioral health, MODA has for over a decade invited our providers to share information with us about their racial background, ethnic background, languages that they speak, religious orientation, specialty in serving LGBTQ members. And so we've been able to maintain that information in a database that we have internally that we're able to use to help members find those providers. And so we get requests passed through to us from our customer service team. We've got a good pipeline there. When members make those requests, they pass those through to our behavioral health team to help members find those providers who match their needs in those respects. We have begun to make progress in making that information available on our external website so that people don't have to go through us to get that. And Melissa, who's going to speak after me, will provide more information about the progress that we're making in that respect. We're also tracking information on intersectionality. So we have African American providers who also identify as Christian or who also identify as LGBTQ plus or specialized in serving that community. So we're able to make some matches on those. We've got fairly limited data on that at this point, but are working to expand that as well. There are a lot of challenges in collecting and being able to use these data. So one of the challenges, of course, is accuracy. We don't want to give out bad information. And one of the things that we found, we rely on providers self-report, and the form that we have used historically for them to provide that information to us, particularly in terms of like race, ethnicity, and religion, didn't distinguish clearly between identifying as such versus having a specialty in serving patients who identify as such. And so we're having to sort through that and really make sure that we're not representing somebody as, for example, African American, when what they really meant was that they have a expertise in serving the African American community. Another challenge with that is that we don't have these data on all of our providers. And so the information that we have available to us underrepresents the scope of diversity of the providers that we actually have in our panel. An additional challenge that I think is pretty universal, but particularly when working with members to help them access these services, is that our website, it distinguishes or has a designation for whether a provider is accepting new patients or not. And that information is notoriously unreliable. Again, we rely on our providers to give us that information, and particularly with behavioral health providers, particularly with small practices, where that information can change from one week to the next. And then the following week, flip again, I've got availability and now my practice is full. It's just really difficult to maintain current information on provider availability. So a lot of times what we end up doing is making phone calls out to providers and say, we've got somebody needing services, be able to provide, offer an appointment to them. Next slide, please. So what I previously speaking to was specific to our behavioral health panel. Here I'm expanding and speaking to medical services as well as behavioral health. There's a number of different ways that we work with our members to help them access providers who, who look like them, who have a similar background. One is, again, the provider search that I mentioned, and our medical team does that as well. They don't have as much of those data in-house on our providers, so they'll go out on the web and they'll look up at OHSU's website and they'll or another hospital system or clinic's website and look for providers who meet that need. In addition, now that we have the Moda Health, the Moda 360 Health Navigators, that opens up additional bandwidth within our system to really provide that sort of individualized, customized assistance to members seeking those services and stick with them until we're able to know that they've actually been able to connect with those providers. Another way that we support members in this respect is that we will make benefit network exceptions or benefit exceptions to allow a member to see a provider based on race, ethnicity, language, if we're not able to meet that need in-house. And we also use those situations as an opportunity. We've got a good collaboration between our behavioral health care coordination team and our contracting team. So when we identify a situation where we have a provider of color who's able to serve a member, but they're out of network and they're requesting single case agreement, we funnel those providers to our network team to work to try to get those providers contracted so that they'll be available for all of our members. And lastly, and Melissa will speak to this in more detail, really prioritizing our contracting efforts for providers of color, providers who speak other languages, providers who are fluent in ASL, and those kinds of providers that are able to meet those specialized needs. So now I would like to turn it over to Melissa Strong, who's our manager of our provider strategy, to give more information about what we're doing from a broader perspective in terms of our strategy for recruiting providers with diverse backgrounds and making that information available to our members.
Okay, thank you, Dan. So my name is Melissa Strong, and as Dan mentioned, I'm going to go a little bit further into what we're doing and what our long-term plans are in terms of bringing more diverse providers into our network. So if you could go to the next slide, please. So as Dan had mentioned, we have some provider diversity data capabilities within our behavioral health providers, but we're now really expanding that to all provider types within Moda Health. So we did begin this initiative this year, and there are two main phases within the overarching initiative. The first phase really focused on expanding our system capabilities to house the additional data, as well as making sure that translates into our online provider directories so that our members have that information available to them as they are looking for a physician that meets their needs. Phase 2 really focuses on the gathering of the enhanced provider data. So this included communications to our entire provider network, inviting them to share more information about themselves and the services that they provide, which we will share here shortly, exactly what we asked them to share. We did focus on using electronic provider surveys that are available on our provider websites, as well as having collaborative conversations with the larger clinics and health systems to determine the best way for them to share that additional data and ensuring that we can be accommodating to that and the additional administrative work that typically goes into sharing that information. So our goal was to have the enhanced data available to display for the providers that we have that information for in our directory by July 1st, which we did meet. So we are very excited to have that capability live today. So if you were to search for your physician in our directory, if we have that data available, it will be there in display. Okay, for our next slide. this slide represents the enhanced data that we invited all of our providers to share with us. So we asked for information on their race, ethnicity, languages spoken by practitioners and clinic staff. If they have completed cultural competency training within the last 12 months, and that is focused on practitioners and clinic staff. Detailed ADA accessibility, translation and interpretation services available, specialized clinic services, gender and gender identity, any specialized medical, behavioral, and dental health expertise and services. So if somebody specializes in care for the LGBTQIA+ community, this is where they could share that. And for behavioral health, maybe any types of therapies that they may specialize in, as well as telehealth and other specialized settings. So in addition to making more information available to our members in our directory, we are going beyond that and working towards seeking more diverse providers that represent communities of colors and the LGBTQIA+ community. So in order to do that, we are focusing on using community partnerships for guidance to help incorporate provider types that are not in our networks today. So an example would be traditional health workers, although we do already incorporate peer support specialists, so we are excited about that. But we are incorporating these additional providers. It may require unique projects to address issues like billing or benefit structures. So really helping to ensure that they have a smooth transition to entering a commercial network, because this may be many of these types of providers' first experiences in working with a health plan. Okay, the next slide. So here we have a list of the different community providers that we are outreaching to for guidance. So some culturally specific community healthcare organizations such as North by Northeast Community Health Clinic, as well as nonprofit organization partners like Cascade AIDS Projects, Familias, and Axion. So other community partners that we can reach out to for some guidance on who we can include in our network to further enhance access to our members. And if there are any questions, I'm going to pass it off to Erica to talk about digital solutions.
Great, thanks, Melissa. And I see that
Erica, yeah, we're bumping up on 4, so whatever you can do to help us out on that, I'd appreciate it.
Yeah, I'm right thinking what you are. So I will just quickly speak to the next 2 slides in that we, as part of Moda 360, we have really been bringing on different digital point solutions. And the point solutions are really giving additional access to members and allowing them to access care in the way that they like to when they want to. And it's also giving them access to more providers and different types of providers. And because we're in a hurry, I won't go into exactly what these are. Next month, we will be giving you an update on Moda 360, so we'll talk more about these point solutions at that point. But just to say that the point solutions that we have and the ones that we're also considering for bringing on in the future, we're definitely looking at how they provide additional access to different types of providers for our members. And we're also looking at their commitment to DEI and their strategies and initiatives that they have as well. So a couple slides ahead, Rose. Great, perfect. So we want to talk to you quickly about social determinants of health, though I wish that we could talk to you all day about this. And we'll, at our update next month, we'll come back and have more time to really speak to what we're doing here. But I'm going to give you just a quick example of how our advocates are using social determinants of health to serve our members and support them. And then I'm going to switch it over to John Klaus, who is our Chief Data Officer, and he's going to talk a little bit more about Moda 360, what we're doing and where we're going with that. So OEBB has our program called C3, and that program really seeks out our high cost, risky members and engages them in the program. And when they engage with C3, we waive the cost sharing for their primary care office visits and their mental health office visits. And then they also get assigned an advocate who works directly with them. And then they can reach out directly to this advocate whenever they have questions or if they have issues navigating the healthcare system. So this is an example of a member that we reached out to engage in the C3 program. And when we reached out to this member, she was a mom, And she actually let us know that her dependent, even though she was the member we were reaching out to, it was actually her dependent who was really needing some advocacy support. So the advocate contacted the dependent, who happened to be a 23-year-old transgender male, needing help finding new providers. So sometimes when you're talking with an advocate, you can build a relationship where you feel comfortable sharing some information that maybe you wouldn't feel super comfortable just calling your insurance company and saying it over the phone. So the dependent shared with the advocate that they felt like their psychiatrist and their PCP weren't really listening to them, and that they also wanted to get set up with a therapist. So the advocate really helped them find providers who were accepting new patients and that worked within the LGBTQ community, and then helped them get set up with those providers. And then they also helped the member get connected with the transgender program at OHSU and help them submit that referral and get them engaged and started on their journey into that program. And as the advocate is working with these members, they're taking the social determinants of health that they're picking up from the member. So these are things that you may not be able to find in claims data or in social determinants of health data sets, but things that the member's really sharing with us. So then we put that into our system so that any other MODA employee, whether it be case manager, care manager, or one of our health navigators, is working with this member, that they can see the conversations that we've had with the member to help. So they're not starting at the very beginning with the person again. That was a really quick overview of how we work with our members, but I really want to switch this over to John, who can talk for the last few minutes about where the work we're doing on health context. John?
Thanks, Erica. We'll go to the next slide. In the interest of time, I think I'll just focus on one slide. This is a topic I'd love to spend an entire day diving into and sharing with you some of the tools that we've developed, akin to what Drew was sharing earlier, in terms of how we look at the population, a number of different dimensions. As Erica's saying, MODA 360's one of its primary objectives is improving member engagement and health outcomes. And I think to do that, we have to overcome one of the challenges in healthcare is that oftentimes we know everything about the patient, but nothing about the person. And so as we started looking into that, race and ethnicity and language, disability are a component of it, sexual orientation and gender identity are a component, the social determinants of health, as defined a number of different ways, are definitely parts of that, and then oral health has a role to play. We cast a net over all of those to capture health context. And this helps us to understand what's going on with the member in between visits to the provider, to allow us to be able to help identify resources and interventions for them. And so health context is our basis for investigating and addressing healthcare inequity, and for being able to match resources to members based on their specific needs. And so we've talked about the role of a health navigator, health advocate to help navigate a sometimes complex healthcare system. We've also introduced a number of third-party solutions designed to bring the best in class services to our members, and being able to curate those solutions, which third-party solutions are ideal for which segments of our membership, and what combination of those third-party solutions. It is not simply a matter of someone's claims history or their clinical diagnosis. It has everything to do with health context. And so I'm hopeful that we will get a chance to dive into some of our tools and models to be able to show you health context in action. But I think it does resonate with the themes we've talked about, Kaiser shared, that Drew and others shared. So I'll yield the floor for the sake of time.
Thank you, John.
Thanks. And maybe we
go ahead.
I was going to say maybe we can fold that a little bit more into the MODA 360 next month and give it a little bit more breathing space.
Perfect. Thank you.
Thanks.
Okay, well, thank you very much. So moving on, in the interest of time, Jeff, we're going to let your innovation work group report go, and you have 2 minutes. Go. Or is he not here?
Yeah, I think we can skip the IWG update, okay. Robert, and just go to CL.
Oh, we can?
Okay.
Okay.
Off the hook, Jeff.
All right. Go, Tom.
Go, Tom. Tom, are you frozen?
No, I'm here. I'm sorry. I had to step out of the room.
Tom?
Can you hear me?
Yeah, I'm waiting. I'm actually waiting for a report from Tom. All right. Well, maybe I can give just a brief summary. I'm going to have to pull up my CL notes real quick. Hold on real quick. Okay, so in See Out today, we got updates on the COVID impact reports. They were a little bit more detailed than what we had later on. We can send out what we'll do is send out the synopsis for everybody to read before the next meeting. Then we had some presentations on telehealth from both MODA and Kaiser. And then we had some dental experience impact reports from the respective providers, and we'll also get that out. I don't want to overspeak since I didn't write good notes on what happened. We'll let the synopsis take care of that. Okay. So we have reached 4:01. Sorry for the rushed ending. And anyway, Rose, I want to thank you as always. Ali, thanks, and thanks to all the OEB staff for making this work. And I will see, public comments. I almost forgot. So Rose, are there any public comments?
No, I don't have any.
Okay, are there any comments from anybody that's participating in this meeting? Okay, so I will call this meeting to an end, and I will see you at the November meeting. Thanks everyone for volunteering your time on this, and we'll see each other soon. Thanks. Bye.
Thank you.
Thank you.